Lovina. I'm a specialist for physical medicine and rehabilitation, or physiatrist. I don't know how it's usually called in your country. And I'm going to share this lecture with a colleague of mine, Ms. Tanja Lakasic, who's a physiotherapist. We both work in this clinic in Zagreb, Croatia, that is specialized for children with developmental disorders. I have to say at the beginning that I'm by no means specialist for rehabilitation of children with Costello syndrome, since it's such a rare condition, but I've been working now almost 20 years with children with different developmental disorders, so I guess I do have some experience with children with developmental problems. I'm going to talk. I wanted to start with this statement that rehabilitation is not the same thing as physical therapy, that is maybe known, maybe not known, but I wanted to start with this because when we met in London at the end of the last year, we spoke about how painful it was to stretch the tendons and how it was forcefully done. And I wanted to put the emphasis of what I'm going to say, that I'm not going to talk about stretching the tendons, I'm not going to talk about strengthening the muscles, I'm not even going to talk about learning how to walk, because physical therapy is so much more than that, and rehabilitation is even much bigger than physical therapy. So I think I'm going to talk about very much wider area. When this is the definition of what is rehabilitation according to World Health Organization, and it says it's a process aimed at enabling disabled persons to reach and maintain their optimal physical, sensory, intellectual, psychological, and social functional levels. Rehabilitation provides disabled people with the tools they need to attain independence and self-determination. What I wanted to stress, that rehabilitation includes also many different aspects of life, includes physical aspects and sensory and intellectual and psychological, social, basically every aspect of life should be included in rehabilitation. But in medical world, we medical experts are still arguing, should we call it rehabilitation, should we call it habilitation? Since rehabilitation, it kind of goes to you had a function and then you lost it and then you are working on having it again. And that is not the case in so many children, especially the children with genetic disorders where their development was never on this typical path. So here is the definition of habilitation. It is the process of assisting a child with achieving developmental skills when impairments have caused delaying or blocking of initial acquisition of the skills. Habilitation can, and I'd say must, include cognitive, social, fine motor, gross motor, and other skills that contribute to mobility, communication, and performance of activities of daily living and enhancing quality of life. So even in this definition, you can see that we have to include everything, every aspect of life. In habilitation, we have to include everything that makes child a child and a future adult. So it cannot be done by one person. It's such a huge area that it needs a team of experts to approach the situation. We need a team, and the integral and central part of the team is, of course, the child and a parent. Then we need some medical experts that are going to work together with the child and a parent in order to help in a way that can be done. And so we have a physiatrist or a medical doctor, then we need physiotherapists, we need occupational therapists, special teacher, speech therapist, psychologist. Let's say that those experts make this closer, integral part of a rehabilitation team that need to work together in order to approach the needs of a child from every aspect that is needed. But we need so many other experts that are not necessarily in the part of this integral part of the team, but we need their opinion and consultation for so many problems that could or come in the way of our work. So we might ask neuropediatrician on advices, or cardiologist, or oncologist, or pediatrician, or geneticist, or social worker, orthopedic surgeon. We might need orthotic engineer or any other experts depending on the problem a child actually have, because the problems that arise or can arise can differ so much from so many different areas, and it's impossible for one person to know everything. So you see the problem, and then you search for the people that can help you find a solution. So when we think about the rehabilitation of children with Costello syndrome, and even wider of rehabilitation of children with rare disorders, what can we do? While we are waiting for a better solution, we have to think about what can be done today. And from a point of a specialist in rehabilitation, I look at the problem in a way that we start doing something to help the development move to the best it is possible. So when a child comes with a developmental problem, first we have to assess, meaning we have to determine developmental level, and then we have to define the status of vital functions and potentially dangerous situations during rehabilitation. Is there a problem with the heart? Is there a problem with breathing, or seizures, or malnutrition? We have to look for all the other things that we have to really look when we are trying to find a solution for a certain problem. Then we define problems that we are going to approach. Said maybe in a different way, we have to assess motor problems and all major systems, cardiovascular, pulmonal, gastrointestinal, but we also have to assess cognitive development. We have to assess sensory system. Can child hear you, see you? What about sleeping? What about feeding? Those are all the areas that are actually affecting a way we will lead rehabilitation, because they're basically affecting the life of a child. Then we all together define problems so we can make a rehabilitation plan. We all sit and agree what are we going to do. What is the main problem that we are going to approach, and then we form rehabilitation team. Although at the beginning I said that rehabilitation has to be comprehensive, we have to include all necessary specialists. It doesn't mean that every child needs every person I've mentioned. Each child is different. One can have these problems, these issues, the other child does not necessarily have those problems. Rehabilitation is extremely individual. We are all very different, and it is the same with children. Problems are different, so we have to make rehabilitation as individual as possible and put together experts that are needed and are going to work together in this moment of time for this problem we are having, which doesn't necessarily mean that tomorrow we're going to need somebody else because some other problems will arise. Then we'll modify it on the spot, see, okay, things are changing, so we have to change. But we have to have a team of experts approaching the problem. Although at the beginning I said, yes, rehabilitation is not the same thing as physical therapy, physiotherapist is an extremely important person in the rehabilitation of children with Costello syndrome and all of the rare disorders that are actually affecting the development of child. Since basically most or all of the children have developmental problems, they need to be included in some kind of a developmental treatment. There are many different developmental treatments present in Croatia. We mostly do NDT. I don't know how is it here, but there are also other different treatments available. Later on, I'm going to tell you more about the rehabilitation methods we use at our clinic, But since we have a child with developmental problems, we have to include a child in developmental treatment. And when we talk about early intervention, that means as early as possible. The second person needed is occupational therapist, and it has to be said that in early ages there is a huge overlap between what a physio does and occupational therapist does, but it's still a person that has to be at least consulted in a way where to go, what to approach. When we think about what is the major job or what does occupational therapist does when he deals with activities of daily life. So maybe you'll think, okay, he's not necessary when the child is 1, 2, 3, but maybe we are forgetting the most important job of a child, and the most important job of a child is to play. And play starts in typical development almost immediately. When in typically developing child is 2 months, he starts to play with his own hands. So play is very, very important in life, and that's the job of a child, to play. And also, another thing that occupational therapist does is help with feeding of a child, which is an enormously big issue. From a point of a parent, and from a point of a child, and then from a point of a rehabilitation expert. From a point of a parent, it's one of the basic instincts is to feed your child. And from the point of a kid, you cannot grow if you are not eating properly, you do not have strength. And from the point of the medical experts, well, if child doesn't have an energy, how can I make him learn something, train something, develop if he simply can't, he's not fed? So that is an issue that has to be approached and solved in the best way possible. Then speech therapist comes. And although speaking is an extremely important thing, speaking is just a means to basically communicate. So what we need is to find a way to communicate with the child. What I've seen in my practice, that there are a lot of parents that are reluctant to use the alternative methods of communication because they think, well, if he can talk with sign language, he will never learn to talk. But it's basically been shown different, because once you show a child how powerful communication is, he'll want it more. So it's just the opposite. He'll be more prone to learn how to speak when he sees that the communication is such a powerful thing. Since many of children have also cognitive issues, we need special teacher at a certain point of time to approach an issue that is present there. There is also an opinion that when you have intellectual impairment, there's nothing to be done, but everybody can learn. I've just spent a weekend learning 11 hours history of Europe about Western and Eastern Roman Empire with my normally developed kid, because she had problem learning, and I sit there and I learned with her with hours, and then she managed. And it's the same with everybody. If there is a problem with something, try to help, and then it will be better. And that is a medical actor, being me, who is kind of a person that is in charge to put all those people together and be the middle person, trying to look for everybody that can help and be sure that everything functions and that everything is covered, and that basically all the wheels are turning as they are supposed to turn. And never forgetting that it is about a child and a parent, and they have to be included in all decision-making process, in everything. So they are an equal partner in this team as can be, if not more equal than any other. Now I'm going to talk a bit more about a rehabilitation method we use at our clinic. It's a bit different, probably, that what you've experienced, but I want to share our experience with you, and then if you have questions later, please ask. So, we use the method that's been developing since 1970s, meaning it's going close to 50 years now. And it's been done according to Professor Stojkovic-Polovina, who has been working at University Clinic at Zagreb, and then later moved to her own clinic. Basically, it's been developed for children with cerebral palsy and children at risk for developing cerebral palsy, since that is the most often condition in childhood leading to impaired development and later problems in life. But with time passing, it's been obvious that there are so many children that have developmental problems, they do not fall to that group of cerebral palsy. It is now even more obvious that for some children who were initially diagnosed with cerebral palsy, well, they do not have cerebral palsy, they have some genetic disorder. So in our clinic, we've been seeing from day to day that although the majority do have neurological base for the development, there are so many children with different rare disorders. I've seen kids with conditions, there are 2 in the world. Lately the child was diagnosed, she was 4th in the world with that condition, or there are 1 in Croatia or 5 in Europe. And so there are not so many experts who can say, okay, I know what to do this child, or you'll probably see 1 or 2 in your career. But still, at the end, it's the same thing. You have a child whose development is not going as it's supposed to, and you have to find a way to help him and find a way to help the parents. So we've adapted what we are doing for the children with other causes. And we need a team as well, as I've shown you before. But what we are trying to do, we are making it a bit more transdisciplinary team, meaning that I know a bit what she's doing and I can do a bit what she's doing. She can cover for occupational therapists, and I know a bit what a speech therapist will say. I'm not as experienced and my knowledge is not as great as they are, but we all have knowledge about what the other one is doing, so it's easier to recognize a problem and then look for solution if maybe you're not looking just at your own, from your own spot and from your own perspective of physio or occupational therapist of speech. We are not just looking, okay, he's not speaking, let's teach him how to speak, but then if you know more, you see he's not holding his head, of course he cannot speak. You have to look at the wider picture in order to maybe be more able to help at a certain problem. And again, the parents and the child have maybe even more important spot and in our approach, and maybe that's one of the best thing I like about my job is having a parent who comes to me and say, look doc, I have this idea. I think we could try this or do this, or let's try it like this, and then we can argue about it. And I say, I can tell from my knowledge what I think is good, and then they say, well, I'm not so sure, what about it? And then we have this equal partners discussion, and I think that's great. That's excellent. And that kind of relations starts borderlining friendship. So 2 days ago I got a message on my Viber from my patient, don't forget to congratulate Tina's birthday. So I did. Okay. Then, what are the most important features of what we are doing that is a bit different from other developmental treatments? We do follow normal motor development. I don't know how familiar you are with NDT or Bobat. I don't know which therapy you had before. But Bobat started with following the normal motor development, and then they said, well, you don't have to. Well, we think you do. And the second feature is the intensity rehabilitation, of which I'm going to tell you more a bit later. So, why do we think you have to follow normal motor development, and what does it basically mean? Well, it basically means, for example, when a child comes and I see him for the first time and he's 12 months old, I don't think, okay, he's 12 months old, he should be walking, let's teach him how to walk, when he, for example, cannot sit, or cannot turn, or cannot hold his head. Basically, I'm not even looking at the age. Age is, to a certain point, irrelevant. I'm looking at what the child can do, and then we are making a plan from there, where the development is maybe at this period of time, regardless of the age. The second reason is that what we are trying to do is not only to achieve a function, we at least try, it doesn't mean it's always possible, it definitely is not always possible, but we try to think about the quality of the function, not only the function by itself. Meaning, it is not just, I'll use the example of walking again, it's not just, let's teach a child to walk. Okay, you have to teach a child to walk, it's very important. Walking is important and mobility is important, but it's also, the quality is also something that makes a difference in life. For example, if I'm walking and I'm limping, okay, I'm walking and I'm still able to come from point A to point B, but basically in 10 years I'm going to start having pain in my hip and probably my knee, and the spine is going to start hurting because I'm not using my body in a way it was meant to be. So whenever possible we have to think about the quality, not only about the function by itself. And in our practice we found that it's easier to be done when we follow normal motor development. I'm talking about young children, I'm not talking about the older children, but basically the youngest ones. So we always try to solve the problem at the lower developmental level. It's impossible to teach a child to walk if he cannot sit. So I think it doesn't make any sense to put him on his leg holding all around and teach him how to walk if he's not able to sit. And it's like in the school, you go to the first grade and to second grade, and then you go and do the harder stuff when you basically master the easier one. It's really, really difficult. For example, if you have a child and you put him in the 7th grade, it's like, wow. You have to know the easier stuff in order to be able to get to other ones. That's the reason we are following normal development, because we think we have better results in that way. Before I go to next slide, about the intensity treatment, I just wanted to tell you to have your minds open and give me time and chance to explain, okay? Well, when we talk about the intensity of rehabilitation, that means that most of the parents that we work with really, really work with their child. Meaning, they work. I'll go about that later. It's not the proper word. They actually are performing rehabilitation with their children for several hours a day. It is extremely different from a child to child. There are children who simply cannot do it in that way, so they do it for half an hour a day. There are children who can. They do it for 6-7 hours a day. It all depends on the child, it depends on the family, it depends on the parent, it depends on the situation. It is not stretching the muscles for several hours. It is not pushing a child for several hours. You have to think about it, all the things you do with your child during the day with the intention to help their environment. Yes, sometimes that is stretching of a muscle, but it's not lasting an hour. But basically it's the way you'll play with your kid. Where you'll put the toy, where will you look with it, at him, how will you approach him. what kind of a toys you're gonna use it. Basically, it's your time spent with your child with the purpose of improving his or her development. What we do is we teach the parents who want to learn, tell them, okay, this is what we think should be done, this is how you can do it, and they do it on a daily basis with their child. What I think it's the best side of it is you do not take your child to an institution. He can or she can stay at home, and he can do it when he is in his best mood, when he wants to. If he's sleepy, you put him to sleep. You don't say, okay, it's 10 o'clock, we have to go. You can do it when you think it's the best time for you. And it also gives you the power of knowledge of being able to do something by yourself, and to understanding and recognizing. And this knowledge that we give a parent is the stuff that makes them at the end saying, you see, I don't think this idea of yours is good. I think we should do it like that. I've noticed that, I don't know, if I do it like this, it doesn't function well. So I try like this. And by giving knowledge to the parents, I'm gaining knowledge. I've learned so much from parents who wanted to learn so we can both learn together. And when I look through the literature, I don't think everybody has this type of intensity, because it is impossible when you want to put it through institution. I mean, nobody can pay for that. At least we in Croatia can't. We have this theory in the background, why is it supposed to be so intensive? And this is this is a theory done by Professor Edelman, who got a Nobel Prize for this, but basically it's just the way the brain is organized, and the fact that maybe if I very, very, very simplify this, I can say that we are all meant to learn throughout the life, and that the brain is able to learn. So if we give him the possibility to do that, then we will hope that the brain will organize itself in a way to use it to its maximal potential. Or when we think about genetic disorder, we are all born with some genetic potential. Somebody is born to be Picasso and somebody is definitely not. So we are all different, and what we are given is different. But it also is not only dependent upon what genes we have, it's also important to think about the environment we are living in. So, for example, if you can imagine, if Einstein was born in the woods of Amazon and never left, always spent there, never saw anything, I don't think that he would be what he is known to be later in his life. You have to have environment that helps your genes reach their full potential. And I believe that that's what rehabilitation is meant to do. Make the environment that helps you bloom, that will get you the best you can. Okay, we have this potential, we cannot go over what God has given us, but I believe that if we push it, we are going to hit a wall, yes, but let's hope we are going to hit the ceiling and not the floor. This classification was done 50 years ago by thinking about all the children with developmental disorders, not specifically the children with genetic disorders and rare disorders. But what I wanted to say that even 50 years ago, it was obvious that you have to start as soon as possible. It is not so there are children when you can start with some type of rehabilitation when they are in intensive care unit. Sometimes it's not possible. You have to have a child that is stable, his condition, so you're not endangering him by. But when a child is stable enough to go home and be taken care of by their parents, well, then very likely that he can be involved in some kind of rehabilitation procedures. We've proven the impact of the intensive rehabilitation in the children with cerebral palsy, which was not easy to do, but even though it is, as I say, the disability that's more often in population. So I don't think we'll ever be able to prove the impact in specific children with rare disorders. Simply we'll never get enough of children to prove it. But I think that the more you work, the more you'll get. So I'm going to give the mic to the colleague of mine to show you the child that she worked with Costello syndrome, just maybe to give you the idea of how it's being done. Tanya, there you go.
Thank you. Hello everyone, my name is Tanya and I'm a physiotherapist. I will present you one special boy. His name is Mate and he's 6 years old. He's a playful and cheerful child, and he has Costello syndrome. His story with Costello begins somewhere around his first birthday when the syndrome was diagnosed. Of all known characteristics of Costello syndrome, he has almost everything, and by that I mean short stature, extra loose skin on the neck, palms of the hands, fingers, soles of the feet, non-cancerous tumors around the face. Characteristic craniofacial features include an abnormally large head, coarse facial features like unusually thick lips and abnormally wide nostrils. Dry hardened skin on the palms of the hands and soles of the feet, abnormally deep crease in the soles and palms, and abnormally flexible joints of the fingers. Cardiomyopathy, arrhythmia and hypoglycemia. Vision problems and setting sun phenomenon. Okay, difficulty feeding. That was the biggest problem, and in 2014 the percutaneous endoscopic gastrostomy was implanted. For us and for the parents, developmental delay and intellectual disability was the big problem too. Mate didn't, he didn't develop his motor skills on the same way that the typically developing child do. And the main reasons for that are hypotonia and joint laxity, ulnar deviation of the wrists and fingers, specialized finger pads, tight Achilles tendon, positional foot deformity, vertical talus, kyphoscoliosis and developmental hip dysplasia. In 2015, he been suffered from the operation of the both hips and he recovered completely. Physical therapy. Okay, this is the most important thing, that if you have a child with intellectual disability, motor, perceptual and cognitive skills should be considered comprehensive assessments. A multidisciplinary team consisting of a doctor, physiotherapist, occupational therapist, psychologist, language and speech pathologist, social worker and special educators will make the best assessment and intervention plan for the child. In all levels of function, motor development, oral function and nutrition, sensory integration, seeing, hearing and intelligence should be assessed. Okay, assessment. Physical therapy starts with assessment. Physiotherapists estimate the child. When I first met Mate, that was the moment that I've introduced myself with diagnosis syndrome Costello. And I have many questions and very few answers. And because of that, I know that the cooperation and communication with parents are the most important. At the beginning, the parents were very frustrated with the whole situation, including next aspects: his diagnosis, his behavior, and his impossibility to work with him. When Mate started with rehabilitation treatment in our clinics, that wasn't the first time that he started with physical therapy. He was doing all required exercise since he was 1 year old. Unfortunately, he didn't succeed any remarkable results. He was very non-cooperative and he refused any contact with everyone. So, at the age of 4, they came to our clinics. And at that moment, he was able to roll on, sit, and stand with support. And that's it. Okay, at that first moment when I spoke him, he was lying down on the floor. He was clenching himself in the head. He continuously repeated that action. He was happy only in the moments of watching the videos on the mobile phone. When I want to touch him, he punched me every time without exception. And he didn't contact with me at all. Okay? And we know that we need a very individual program. And this is our guidelines or tips for that. Communication. I was aware that I know that I must start to communicate with that child. We often try to model our style of interaction after parent style. It's familiar to the child and most likely to be successful. Okay, follow the child's lead. What does that mean? The child must be motivated to perform the particular skill. Trying to impose your will on a child with an intellectual disability is a losing game. For example, he gave me a 2 repetition at a particular skill, and then he insisted on moving on. Okay. Next tip, we must know when to quit. So we must set up the game or exercise so that the child is successful and avoid frustration. We must avoid frustration with or in physical therapy. And how we do it? We must be strategic. We must be strategic in planning session. Okay, we will tackle the most difficult skills first before the child becomes tired. Alternate difficult skills with easier ones to give the child time to recover his strength. And we must be strategic in providing support. Provide as little support as possible while still allowing the child to succeed, and remove the support as soon as possible. Okay, you have, this is me and Marta now. We have a left picture and right picture. On left picture, he stands with support. On right, he moves on and he can stand without support, and he's moving on forward. Okay, this is progress. But for me, the biggest progress was that he is looking at me. When I said come, he came. Okay? We have a contact. After that, we can everything. And we can learn new skills. Okay, how we learn new skills? I observe what the skill the child has already mastered on his or her own. Then determine what the child is ready to learn next. Develop a way to teach him that skill. Okay, we break the skill down into its components part and then practice the skill. Okay, I'm very sorry, we have technical problems. I can't show you the video, but Andrea can on this
Little one.
Just for those who are close. Nobody can see anything, right?
We are learning new skills on this video. This is final version. Hold on.
No, he's about to start walking.
Okay. That's great.
Okay. I don't know why it works here and not there.
I'm very sorry, but we will show you if you want.
He's just walking and playing.
And this is physical therapy, okay?
Yeah, not strengthening the abdominal muscles.
The lastly and the most important, we must teach the parents how to practice the skill with their child. Okay, why is this important? The parent can practice the skill when the child is feeling rested and strong. And the skills can be incorporated in the daily routine. Okay. Through practice and repetition, the child will develop strength and efficiency, leading to mastery of the skill.
And since that time, a lot of the other